Hey everyone, this is the Nips and Sips podcast featuring me. I'm Dr. Jeremy Boyd and my usual partner in crime over there, Dr. Brandon Cruz. Today we're going to be talking about the infamous throwers, arm or whole examination from top to bottom. We're seeing a lot more throwing injuries coming late, especially post-COVID after such a long break between sports. But before I get too much into it, Brandon, how's it going?
Oh, well, Jer, excited to do another podcast, get this back on the road here. And yeah, you said throwers, and while we're probably going to be talking more throwers, I guess you could kind of lump in, overhead athletes in general, maybe some swimmers, tennis players that have like-minded motions. I shouldn't say like-minded, but similar motions, or even maybe construction workers or manual laborers that work overhead. Some of this stuff may apply to them, but typically we're looking at the baseball players, more specifically pitchers or maybe catchers, maybe even quarterbacks too, but typically known as or viewed as baseball players. But yeah, with that, Jay, before we dive into the nuts and bolts, what do we have for drinks today?
All right. So as I mentioned, previous podcast, now I have a beer of the month club going on. And this one's from Salt Flats in Salt Lake City, Utah. Picked it because it says flat out, and a lot of throwers and overhead athletes go flat out, balls to the walls. So it's a Hefeweizen. It's apparently their flagship beer. Drinking it through my Artillery Brewing company. Back in the day I had a sweet gun of an arm, but yeah, no mas. Not really. I've always had a kind of a fancy arm, but a living dream. But yeah, I'll give my rating. Brandon, you still on the beer train, or is that
you'll find out? You'll find out. You
right.
do.
Let me get my nice steady pour in.
Don't want to tip off our audience what we got going on. Where's Artillery?
Artillery's in Westchester, PA.
Okay.
Me and the missus and two friends of ours went on a little brewery tour over there, and it was a good time. So this one was like all military themed. There's a couple of those out there. It's a Flagship Brewery in Ship Bottom. They're another one, or Forked Lakes, maybe that's where it was. So I kind of like that, veteran owned and that sort of stuff. But it's cool. You get guns and Army helmets and stuff. So I always like that type of theme. But let me give him my taste. That's refreshing. I like it. Really kind of hit the banana cloves there.
Drum roll. What is the scoring?
I'm going to give it 7.6. So usually I'm not like Hefeweizen. Yeah, usually like here and there. But it's nice. It's refreshing. I dig it.
Very nice.
All right, here we go.
Thanks. A little low for you of late. So I'm not on the beer train today.
The streak has ended.
Before I'm gonna talk about my beverage of choice, I love a glass here. Quail Creek. I had went to has a little Quail Creek symbol there. I don't know if you could see there. Got the condensation from the ice building up, but went to Naples back in early June. Buddy has a house down there. So we spent a couple days there, just a little getaway. But I have a set of clients that have a country club down there, and they were kind enough to let us play at their club, Quail Creek Country Club. It was a great course, great, beautiful facilities. It's amazing. So I kind of got a set of glasses there as a little memento right there. So that's my glass, and my drink is a Bacardi Anejo. 4 years aged, and this is from a client. Actually, you know him. This is from the good-looking or sexy Manny, as he refers to himself. Our patient, we did an eval on him a while ago. He bought this for me for my birthday. He's been asking me if I've used it yet or tried it, and I said no. I'm saving it for the podcast. He asked for a shout out, so that's our shout out. Now he says the good-looking Manny, not the ugly Manny. So for our audience, we have an intern named Manny as well. The patient's name is Manny. They have a kind of inside joke. Manny, the patient, is a character, likes to is a true ball buster. So he likes to joke around with the other Manny how he's better looking one. So this is from him. Let me actually open it up. And Manny's gonna listen to this. We're gonna give him the link when
all right,
when it's out. And very smooth, good, a little vanilla-y taste to it. I love it. Definitely going to be a big drink of choice for me in the future. So Manny, thank you very much.
So that's a rum, right?
Yeah, it's a rum. It's Anejo. It's actually in the back. I can read like you usually do here. For the elevated cocktail, aged for 4 years under the Caribbean sun, with notes of mild vanilla, toasted oak, clove, and honey. Perfect rum to enhance your cocktail. Except I'm having a cocktail. I'm just having it on the rocks.
Oh, there we go.
Pure day. So
on the rocks to throwing rocks, right?
What's up?
From on the rocks to throwing rocks.
On rocks, yes. So. All right, man. So with that said, what do you want to get into? Where do you want to start with the throwers here? I know you said you've been seeing a few more UCLs and things like that. Mm-hmm. You did a sports fellowship program that you just finished. I'm assuming you had some great either courses or sections that covered it. I know a few years back, actually in 2015, my first exposure to your I guess mentor and the owner of your fellowship program, he did a few breakout sessions at Aon regarding the throwing shoulder, overhead athlete, throwers paradox, things like that. So I'm just kind of based off that, assuming you guys had some good in-depth conversations.
Mm-hmm. Yeah, so Toko's really, really impressive when it comes to the overhead athlete and the throwing athlete. I believe that's a big part of his niche, especially in his private practice, because I know he does a lot of stuff for the Texans as well. So, but from what I know, he sees a lot of baseball guys and everything like that. So, yeah, we had a whole section on upper extremity like performance and diagnostics and rehab, and all about like, the throwing kinematics and stuff. So that was the cool thing about my fellowship. All the, faculty were pretty well versed in this, something I wasn't really exposed to in residency, which obviously is the goal is to, work on your ability to differentiate, diagnose, and, get to, symptom modulation and, help the patient out. But especially things sometimes don't quite add up, especially when we're working into the high level or elite athlete. But yeah, I mean, it went really in depth of like understanding what is required almost at every single joint, and to have things on your radar beyond just let's say the UCL, the elbow, or the shoulder for like labral tears. So it went into like in depth of the what we need for each hip. For the stance leg, we're going to need, adequate external rotation, and internal rotation for the landing or stride foot. It went into depth of, if you're too far internally rotated on your throwing or your pitching scheme, for that lead leg, it can lead to more back issues and hip issues. Versus if you're too opened up or externally rotated, it can lead to more anterior shoulder compression or injuries, and like slap tears. So we really went into depth of things, broke down things by certain degrees of like what to expect at the shoulder if you abduct too much versus not enough, what potential injuries can happen. And don't obviously want to go too much into the details with that. But pretty much what I, in summary, definitely what helped me was looking at the patient as a whole. So, I would get a couple differential, direct access, throwing athletes or overhead athletes, it's pretty common. But, a lot of them would come obviously post-op. Hopefully get into the scene long enough and you help enough of these guys, they start referring their friends and stuff before they get to that point where they, tear their labrum or tear their UCL and stuff. But looking at, especially during those early phases, post-op labrum or UCL or cuff, where you're limited by what you can potentially do at the joint, like let's say labrum, they're only in the passive phases and so forth. what can we do to help this pitcher or thrower out so that they're most efficient and I guess safest when they go back? Can I do some things at the hip? Can I check their ankles and make sure they have adequate ankle dorsiflexion so they're not collapsing in the foot, which leads valgus, which leads to hip and then back and up the whole chain. So that's something I never really quite did. I would just spend my time really mobilizing, getting everything right in the upper extremity and fail to look things down at even the lower extremity and stuff. So that's pretty much kind of where I've changed focus of late. It's definitely helped out. It's definitely led to some more referrals. And obviously I'm definitely focusing on the injured site, but looking at the whole picture, we talk about regional interdependence and kind of the above and below, but what are we looking 4 or 5 joints down the chain? And I think that's especially important in all athletics, but definitely in things such as the pitch or the throw, which requires, I believe the pitch is the fastest movement in the human body. I think it's like 6,000 newtons per second or degrees per second. But yeah, what about you, Brandon? I know I kind of went off on a tear there.
Yeah, I think, a lot of it, like you said, and hopefully with this podcast, we can kind of begin to organize some people's thoughts and just give them background information. As today we'll be covering kind of more the evaluation and education part. And, part 2 of this in another episode will be, interventions and things like that. But a lot of these pathologies, that we get these diagnoses, biceps tendonitis, rotator cuff pathology, tendonitis, tendinopathy, bursa, impingement, whatever the case may be, little league elbow, which kind of is just encompassing in these umbrella terms. A lot of these are stemming from deeper issues or deeper impairments that we need to be able to identify, like you're saying, and whether that's identifying it at the site of pain, or more often it's diving, somewhere along the kinetic chain, whether it's, into the shoulder, C-spine, T-spine, or even going a step beyond and that into the lower extremity. But I think that some of the big things before we, even go into the nuts and bolts is kind of understanding, the evolution of this and why more and more athletes or throwers are dealing with these shoulder and elbow injuries. It's not just because they're lacking hip motion, or, we hear the one story of the Dodgers player that had their great toe mobilized and it saved them from getting Tommy John surgery. But, we're looking at from, 25 years ago or so, in 95 to 2000, only, I believe the stats I'm looking at, 38 out of 276 high school players and younger had Tommy John surgery. Fast forward to 2001 to 2005, it jumped to 158, and 2010 was 182, and I'm sure that number has gone even higher. Oh, yeah. There's a 3 to 5 fold increase, if not more, in these pathologies. So what are we missing as rehab professionals? What are coaches missing or not understanding? What has changed in the game from 25 years ago to now? And I would say a lot of it's overuse. Mm-hmm. They've gone from playing, baseball once a year in the spring / into the summer to playing, depending on what region you are, 3 seasons, spring, summer, fall. And if you're, in a warm climate, you're playing year round. Mm-hmm. There's stats here that show, pitching competitively for greater than 8 months of the year, you're, anywhere from 5 times or more likely to increase your risk of injury. Mm-hmm. Pitching regularly with arm fatigue or a fatigued arm, not allowing enough days rest, not being old enough to tolerate the amount that you're pitching is going to, increase risk of injury by 36 times. Mm-hmm. And then, pitch counts as well. There's a pitch count, pitching more than 80 pitches in a session or in a day is also going to, increase your risk factor about 4 times or so. Mm-hmm. Do we count pitches versus throwing, or just regular throwers? Do we count warm-up tosses in that, or are we just talking in-game pitches? The research really isn't there to say, but I think we should shed light on that area. And even with the protocols that are out now, there's not a ton of research that really, points us for every single person. Yes, we can draw linkages or parallel, like I just stated, but every person is going to be slightly different. Somebody who doesn't pitch as much, maybe they only pitch 1 or 2 seasons of the year, might be able to tolerate a little bit more than somebody who's pitching all the time. Versus now somebody who's not pitching at all and then jumps into, pitching 3 days a week or 2 days a week. Again, you're going to increase it. Let's factor in breaking pitches. Slider has, increased risk of about 86% for elbow pain versus a curveball, which is about 52% for shoulder pain. So at what age do we start encouraging our pitchers to throw breaking pitches? It should be later on. Stay with fastball, locate your fastball, start with, then progress to a changeup. And that's probably all you need to. You get to about maybe 16, 17 years old. And then when you're older, you're physically stronger, you're more skeletally mature, you can start adding in some of these breaking pitches. But, I have pitchers coming in, I have treated pitchers or throwers that, are trying to throw a breaking ball at 12, 13 years old. That's just, you're not physically, strong enough, and you don't have that maturation in your skeletal system to be able to handle those forces for now a longer period of time. And by the time, and you're seeing it in the major leagues, but these guys are having surgeries at their first, second year in the league, third year in the league, if they even make it that long. Some of them kind of blow out earlier. I have a story here about Kerry Wood. For those of you, Kerry Wood was a phenom back in the late 90s for the Cubs. And actually the story here goes, he threw in high school, senior year, his final start before he got drafted in 95, threw 175 pitches in a doubleheader. His father and coach had kind of defended that pitch count, saying it's not the first time he has thrown that much. He can handle it. He's fine. So he gets drafted. And a couple years later, he throws 133 pitches on August 26th, and then 116 pitches on August 31st. So within 5 days, he threw almost 250 pitches. And what do you know? September 1st, wakes up with throbbing elbow. Later on, he ends up, he pitches in the playoffs, and then, that following season of spring training undergoes Tommy John surgery, and he was never the same. So, that's going all the way back. So, while we may not have a ton of research out there on who gets to throw what and when, but, let's at least utilize the information that we have and not overthrow, have these pitchers overthrow, give them breaks, encourage other sports. And I think this comes down to really educating, our patients, and not just coming in, oh, where do you have pain? Your shoulder or your elbow? Okay, let's just get into treating that. But taking that time, and maybe it's that first session where you're just sitting down and getting to understand how much they're throwing, how many teams are they on. A lot of these kids, at least up in my area, on 2 or 3 teams. They play town ball, they play high school ball, then they play in a serious traveling league. And because they didn't pitch in one game for their team, for one team, doesn't mean they're not pitching for the other team. So having these conversations with your patient, taking time to understand where they're coming from, what they're enduring, and then trying to address modifiable factors, possibly pitching mechanics. If that's not your wheelhouse, don't do it. Have them go to a pitching coach. But have these discussions with them, their parent, their coaches, about that frequency. And then the things that we can change. Are they lacking range of motion? Are they have too much motion? Is there not enough dynamic control? Do they have too much shoulder flexibility, rotator cuff imbalances, or periscapular, force coupling issues? Do they have poor neuromuscular control, as you stated, core or lower extremity strength and balance? These are all things that we can, then modify and have discussions with. And I think that's where, especially when you're dealing with these younger patients, probably the 11 through 15, 16-year-olds. I think that's where more of our time needs to go, and not just treating that side of pain.
Mm-hmm. Yeah, but good points. And constant theme here is education is the key there. And based off of what you said, and Tommy John's on the rise and that sort of stuff, there I still don't believe there's a misnomer or misunderstanding that people and pitchers and parents and coaches believe that having Tommy John surgery actually improves performance.
Yeah.
We're looking at a small number of individuals who are able to do the successful rehabilitation and return to performance. But overall, statistically speaking, I think it was like only like 40 some odd percent fully kind of get back, 40 to 60% fully get back to everything that they prior performance levels and that sort of stuff. So I've heard from other parents like it's not that bad of a thing. I'm like, well, no, the rehab's long, and it's not a guarantee that you get all the way back. And I think having that understanding, and more people need to know, and they need to come from coaches and parents, that we don't just blow our kids' elbows or shoulders out until they can get reconstructed. And I think the idea of reconstructed seems like, oh, we can make it bigger, better. Was it Bionic Man?
Oh, yeah, $1 million man.
Yeah. Because that's really not the case. And you got to think about that time that you lost a year of that. You're losing all your capacity, your tissues are getting weaker. You got some atrophy from the non-strengthening phases of things. So I don't think there's any really periods where I can think that's the most ideal situation, is to let's just get reconstructed. But I think that's something I've seen as well, is sometimes even like from what I've heard from some of these post-op patients, is that it's like partial tears and that sort of stuff, where they given a chance to actually do the thorough rehabilitation, and maybe they didn't need to have the full one. Yes, there's more risk and that sort of stuff, but it's just like, all right, let's just go and get it done, because let's face it, maybe they'll be a little bit better afterwards. I think the only reason why some people get better afterwards is this is the first opportunity for them to actually sit down, start actually applying some training. You'd be surprised how many people make it to the highest level of performance and athletics with just playing their sport and doing minimal outside of that. We just always like make the assumption like, oh, they're playing D1 or they're playing at the pro level, so they must be doing all the cool stuff that you see on social media and performance and that sort of stuff. And a lot of them, that's really not the case at all across all sports spectrums. Some that are left up to their own kind of decisions, and it's not until a significant injury such as a UCL or a slap tear where they're forced to actually take a step back, let the tissues calm down and heal, and start working on all these other areas, and working on improving mechanics and strength and building up resilience and that sort of stuff. So hopefully a couple parents and coaches and players may be listening to this, and maybe change up their mindset in regards to this. Is you have a long, lengthy career, ideally, and it can be managed very, very well if you listen to things what professionals are saying. Monitor your pitch counts, your styles of pitching, and don't overload it. Yeah, I agree. I'm seeing more and more, especially multiple teams for pitchers in the same exact season. It used to be like no one messed with high school. You played high school, there was no other seasons going on. That was it, flat. Now you have travel ball while you're playing high school. And that's just way too much, I think. And it's leading to all these injuries and stuff. So I had this recently had a good shoulder issue. Slap there was his dad was like, I didn't expect my kid to have be 14 and throwing 80 miles per hour. So I'm trying to do all these sort of things and get him on all these sort of teams. I'm like, well, you need to probably do the opposite and start surrounding him by, a performance person, medical professional, versus just signing him up for more teams. And he was like pitching multiple times per week. Especially now is another shift in focus is if we're going on the throwers component is pitchers only. Like that was never really a thing. I was like, all right, we want the kids to play, but now I've heard as young as like 12, 13, 14, where kids, all they do is pitch. It used to be like, all right, you pitch this week and the rest of the week you're playing like, first, third, whatever it may be. But now you're already getting, it's one thing about sports specialization. Now we're getting position specialization super, super early. And especially with all the strain and compression forces that throwing has, we really need to mix things up. But yeah, maybe a couple people listening, and hopefully this helps out. But
yeah, we're probably preaching to the choir here. Obviously, most of our audience is PTs, not coaches. But you make a point about signing players up for more teams, and it's I've heard patient or parents like, oh, my kid needs to be found, or like he needs to get looked at. The scouts are going to be there. Like, no, if your kid's good enough, they'll find him. Yeah. They'll find him no matter what.
They find some kid out in the sticks of Iowa, cornfields, and they bring him out. They're going to find your kid. Everyone believes.
No offense to anyone living in Iowa.
Huh? No offense. But I think I like someone called from Iowa recently. Or I had one of my players. He did a tournament out in Iowa.
Out there. Yeah, people travel all the way. Let's kind of go back onto injuries here, and shoulders, and Jer, when we're talking about examination, somebody comes in with diagnosis of biceps tendonitis, or some type of vague shoulder pain, maybe even labral tear. What are you thinking? At least on the special test side, I think a lot of times, especially younger clinicians, will put a lot of stock into special tests, hoping that that's going to give them the answer that they need, and oftentimes they don't. If we can break down diagnosis by diagnosis, what special tests we should be using, but what other impairments or possible things could be going on.
Yeah, definitely. So I'll go with the special test first, and then what I actually will do, especially for the throwers and everything like that. Labrum's the big one to kind of go for. So that's when we start doing biceps load too. I don't go crazy with the compression ones, because unlikely that it was a compression based labral injury. It's kind of more of a throwing or traction one. So there's the resistive pronator test, kind of similar to the biceps load, it's just now in pronation. There's a Kim and jerk test that you can also do, but that was more for the posterior labrum. So those are a little bit more rare, but those are usually kind of the big ones I go for in my throwers labral injury, unless again something happened, they're running or sliding to first or something, or not first, second, and they land it on an outstretched arm. And then I'm going to do like the compression or a clunk test. So those are the labral test. Every once in a while you get a dislocation where you can do the relocation or the kind of posterior glide to the shoulder, which I'll probably use more from an understanding of a symptom modification sort of thing versus purely the shoulder dislocated and resetting into place. So those are more the special tests I'll implement. But it's pretty rare, especially when they're coming along the lines of most cases. They're coming in from a referral, they get the MRI and that sort of thing it may be. But first thing if we're going special tests, I'm going more looking at the C-spine. When you mentioned biceps tendonitis, which I think is a fairly popular one, I can say it's almost never, I want to say there's never a never, a biceps sort of thing. It's, it's classic, the vague rub the shoulder pain right here. But I found more worth looking at the cervical and the thoracic spine, one from a movement sort of exam, seeing enough, thoracic extension, rotation. Also, your head's moving, especially when you're pitching. So cervical rotation, especially. So really diving in, seeing how they're doing in like a quadrant position as they're starting to wind up. And we talk about our UPA assessments in previous podcasts. So that's where I really start to, I want to make sure it's not the case, because if I guess maybe I got jaded from all the asymptomatic studies of like MRIs and those sort of things. I think they did a pretty big study on the Blue Jays throwing. I think it was Blue Jays.
Minor leaguers.
Huh? The minor
leaguers,
they're minor
right?
league. Blue Jay organization.
Blue Jay farm system, though. Yeah.
Yeah, that'd be the Canadians. Of course, American would do it. But in finding so many pathologies in all of them, and getting in the asymptomatic ones, do I really care about confirming a labral tear if understanding a lot of it can potentially be asymptomatic? I'm looking at the other things that could potentially, maybe that labral tear, it's been there for, forever. It's been there for a couple of years, especially in our older athletes. What else is going on? So, a lot of it, I feel like, from my experience, can be modulated from the cervical or thoracic spine. And then, after I check out the rotation and movements of the T-spine, especially, looking at, the scapula, playing around with things, I'll get them into the throwing position. And usually it's, I got a pinch here. Sometimes also a pinch into the posterior compartment of the shoulder. And what can I do right there and then? Can I modulate things by changing position of the scapula, or the position of the humeral head, even SC joint, AC joint. I'll do all those sort of things before like really putting a lot of weight into a, I guess, pathological diagnostic special test. My mindset's always, well, what can I do to make this person better? And let's find that out through those type of testings. And sometimes I'll test out strength at the 99, but really I use that as like a test retest. Usually they're pretty weak into this position. What can I do to change things, modulate things, and then retest it? Because people are like, oh, it's 3 or 4-5 strength and pain. I guess we just gotta keep having them do this with the band. All right, well, if I change up something and all of a sudden they're 4+5, was that real truly weakness, or things need to be positioned in a better position for them? But what about you there, Brandon?
Yeah, a couple of things to add on to what you said, and then I'll kind of dive into things a little deeper on where to hedge your bets with certain age groups with pathologies and things like that. You talk about biceps tendon or tendonitis or biceps pain, and it's vague, right? You kind of point to that general anterior shoulder region, but you mentioned the neck. C5, C6 kind of corresponds to that shoulder region, and you look at the nerve roots. The nerve roots tend to be the largest in that region, and the foramina is the smallest there. So is there, and like you said, there's rotation or side bend or torquing going on, especially with that late cocking phase, and are trying to generate force. And if they don't have that stability dynamically there, or enough range of motion externally or internally, are they going to be just kind of cranking on that region there, kind of loading, provoking, and irritating that region in the neck? And they're going to get a referral into that side lateral shoulder, which would be confused as impingement, or anterior shoulder, which can be confused as biceps tendinopathy or tendonitis. And you get a thrower who's constantly pitching, and there's some inflammation, irritation. It's going to show up as something on an MRI. So we can't necessarily go by that. There can also be, especially on the younger groups, you're maybe 11 through 14, 15-year-olds, some proximal humeral epiphysitis, right? So some inflammation on that growth region, which yeah, again, they're going to be sensitive along that biceps area, or maybe a lateral shoulder, or with or have pain with resisted ER, right? So then we think, oh, they're weaker. Let's do a zillion external rotator cuff exercises.
Mm-hmm.
So I just kind of wanted to highlight that. But it depends on the age group. And you brought up that study. Obviously, that study is going to be done on, a bunch of late teenagers, 18, 19, 20, 21-year-olds. But, I would say, in the clinic, on most orthopedic clinics, you're probably getting that younger patient. So chances are that 12, 13, 14-year-old, 15-year-old's not going to have a torn rotator cuff. They're not going to have a labral tear. They're too young. Their tissues are too pliable. There might be some inflammation, but their chances are not going to have a tear. So what else is going on? And that's where, just to kind of round out what you're saying, looking at scapular control, looking at the neck, looking at their movement mechanics, looking at some of the other modifiable factors. Can we improve that? Do they have enough posterior glide to allow for, external rotation? Though in school we're taught, external rotation is anterior glide, but chances are that glenohumeral or head of the humerus is typically translating forward. They can't control it dynamically enough with their dynamic stabilizers and the scapular stabilizers there. Moving to the elbow, same thing. That UCL at age 13, 14, chances are that's not tearing. Chances are you're going to get some type of medial apophysitis, that is stressing or irritating that medial side of the elbow. Laterally, differentially diagnosing, you're looking at Painter's syndrome or OCD, from the compression of the capitulum. So these are things that, diagnostically we want to be able to look at and not just jump into, oh, it's a tendonitis or it's an impingement. It's a tear. A lot of the, diving into special tests, and you said the biceps load test, that's probably the one with the highest psychometrics of, or biceps load 2 test. Let me clarify that. What the sensitivity is a 90. So your rule out's a 90 and your sensitivity, sensitivity is a 90, your specificity is a 97. So your specificity, or being specific to a local tissue or area, is 97% specific. That's what we mean by looking at those labor ones. The O'Brien's compression tests, they're all over the place. You look at, some of the O'Brien studies, it shows 90 and 100% accuracy. You look at somebody else's test and it's showing like 50%. So maybe that's just something you use. What's up?
Better for the AC joint than
the
labral.
Exactly. So you have to understand, and I was having this conversation earlier with an intern, understand what these special tests are actually looking at before you just use them and hope that they're going to give you an answer, because chances are they're not. Even if you look at some of the impingement tests, we'll do the 3-item test, right? Painful arc, Hawkins, and weakness with resisted ER. All 3 are positive, gives you a 95% likely that there's something going on. It's not telling you what structure is being compressed or irritated. Same thing with a rotator cuff tear, drop arm, painful arc, and weakness with ER. You have all positive of those. It shows you a full thickness tear, not a partial thickness. And even though it shows you a full thickness, it doesn't show you or tell you what structure is torn, which one of the rotator cuffs are torn. So, it's important to understand that, there's some flaws in these special tests, and what other diagnoses are there. And like we were saying, what other impairments or limitations are occurring that are leading to the diagnosis that you're getting, or that the diagnosis that you'll probably just give the patient or has been given to the patient, whether it's a breakdown in the kinetic chain, from lower extremity all the way up, some type of lack or strength or endurance, scapular dyskinesis, too much motion, not enough motion, overuse. Like you said, the cervical spine, thoracic spine, and ribs play a huge component in identifying that shoulder. Though the rib area is not always agreed upon on what role it plays, or being able to pinpoint, impairments to or pain to, but it definitely definitely has some correlation. So we can't throw the baby out with the bathwater just because there's not enough on it.
And to go off of what you're saying with special tests, you gotta also ask yourself what other structures are being tested in this position. So take the biceps load 2 test or the pronator load test and all that sort of stuff. You're also putting that person not only to stress the anterior structures, but putting them in the maybe upper limb tension test, especially as we start to kind of crank back. And that had actually a conversation with Michael Shallock. He's just like, those upper limb tension tests, they're not designed for everybody. Doing a gymnast who's going all the way back into their end range of motion, this is nothing to them, or a pitcher, this is nothing to them. Their system gets wound up more towards the end. But you got to take into account what other structures are being tested. So yeah, you may get a positive test because you put them into this position, but can it possibly be a neural dynamics issue? So that's something to look at, and then really diving into where they have their pain, what phase of each component of like the throw or whatever their sport may be, the stroke and the swim, or the serve in tennis. That's going to help kind of lead down towards more differential diagnosing. Is it at the windup, are we making that assumption, or is it all the way through follow through? Because that's going to lead to different structures and different stressors. And we're talking about nerves and a follow through, or maybe again some more touch of radial nerve versus median nerve. So just kind of going off of that and really challenging the idea. A lot of our special tests were made ages ago by someone who put their life's work in, and at that time thought that this test was testing this structure out. So O'Brien's compression, thought it was a labral issue, but all his particular study was 100% specific and sensitive, and found other things were going on. And hell, congrats, you found a good test for the AC joint. Be happy with it. But that wasn't the first thing on his radar with things, and that's a lot of it with these special tests is we're basing things off of things that were made 20, 30, 40 years ago. I think a good quote is it's made by individuals that were building a plane as they're flying it. I think that came from a Jack Cook's interview and that sort of stuff. So that's we always say it in this podcast of like, don't kid yourself. Everything that you're doing, whether from an examination perspective or a treatment perspective, you don't know exactly what's going on. So be willing to challenge what's exactly happening and look at it from all facets. And that's why I think a lot of what I was discussing before, the symptom modification components hold some value of like, all right, it may or may not be the labrum, but I can affect it positively, and that sort of stuff. But and another question I was going to ask you, because this is off the cuff here. Right. Speaking of, you're talking about you have some people with little leaguer shoulder and elbow and that sort of stuff. Something help out potentially our younger clients, or our younger therapists and stuff. How long do you treat your younger patients for? Let's say if you have them either differentially diagnosing for, or direct access, how long do you treat them before maybe they have some concerns of growth plate injury or something that's a little bit more trickier to find? Do you kind of stick with it for a while? Do you refer out? Are you a little bit more diligent with them? I've had some different opinions from different therapists I can go into. Where I used to work and that sort of stuff, he had mentality, don't mess around with kids. Adults, he's just like, go away. But like kids, he had a very short kind of leash with them. I just want to kind of get your thoughts.
Yeah, I would say most of the adolescents that come in that are pitchers have come through, they've seen their doctor first. They've probably had an x-ray, or they've been told to not throw for 4 weeks. The most recent one actually was put in a cast for 4 weeks before he was allowed to come. He had a slight stress fracture of that medial elbow or epicondyle. So, that's the most recent one. I've had swimmers come in, more direct access. And, we're working with them. And I'd say at that point, honestly, it's more of really trying to get them to modify their schedule. Like I said before, and I honestly, a lot of times if I'm very confident in that, there's no red flags, I'll try and steer them away from the physician, at least up in my region, right, wrong, or indifferent, because, then it goes down that over medicalization. All right, well, let's get you an x-ray. An x-ray is not going to show a fracture, or, an x-ray is going to pick up a fracture. Sorry, this kid doesn't have a fracture. There's no trauma with that, right? Unless there's some type of red flag, random bone health. But let's say we've screened all that out. Okay, let's now get an MRI. All right, let's get you on some NSAIDs. Let's get you on an injection. I don't think a 14-year-old girl or a 13-year-old girl needs to go on there. She just needs to give her body a rest and strengthen up some other areas. All right. And, you see it, their parents want them in, two clubs, and they're swimming 8 days a week. Well, have that conversation of, there's going to be, this flare up, this irritation. We're going to do what we can. But then it's on the other side. Well, if we had no intervention, how bad would they be? So I don't know if that directly answers your question, but that's based on kind of, what I've seen. But I guess largely I'm giving, a handful of visits, 3 to 5 to make some type of change. But it's also understanding, okay, how much of it is just an inflammatory process that we need to calm some things down? Did we get you better and then you went and through again and now it flared it up? To me, that's not warranting. All right, you're not progressing. You progressed, you just then regressed because you went and did what you weren't supposed to do. You reopened that scab. So I think a lot of factors go into that. But as a general rule of thumb, I try and give it, typically 3 to 5 sessions for most things, before we made the call of, okay, what's going on here, or at least having a conversation. And I think that the big thing is just having that conversation with the parent, with the kid, depending on what age that kid is, so you get everyone on board, and 2, get that expectation and timeline of what our prognosis needs to be. I think that's huge, that communication, and letting people know your plan. Yeah. If your patient doesn't know your plan, or the parent in this case doesn't know your plan, and you may have to tell them several times, and that plan may change week to week or session to session, depending on how they respond, or there's a lot of other factors I just can't cover all on the podcast.
Yeah.
That, just kind of happen within clinic and within the patient and in the moment, that you just have to be aware of and be willing to adjust if you need to.
I think you brought up some good points there. And it's sometimes tough. I'll talk about modifying their schedule, is, especially with these, I guess, over involved parents and that sort of stuff, or even coaches, where you can give them all the best advice in the world, talk about research, talk about these sort of things. They see that they're clearly not getting better with just keeping doing their sport, and they'll, it's like deers in the headlights when we suggest anything about, let's try and plan rest days and that sort of stuff. Speaking of swimmers, I think swimmers, gymnasts, they go hand in hand, as I guess the most overused and abused athletes. We had a PT at one of our courses who's a swim coach, and he even said himself, like, with his best athlete, his best swimmer, he'll keep them in the water even if they're hurting, because it's that important for them to be, swimming and just competing. And I was kind of baffled by that, knowing he's an orthopedic therapist. And he would downright, he was like, yeah, I know, it's like you battle with his two sides of his head. And I was just like, if we can't get our own profession to kind of listen in on that, what can we do to expect like a parent or a coach that has their all-star, their baby who's, gonna get that D1 scholarship and get to the pro level and pay off everything. So a little tough. We talked about, also Brandon talked about, trying to, limit over medicalization and that sort of stuff. I agree. Especially because, you can pretty much operate on anyone or inject anything at this point in time at any age. But for some people, try if that's kind of your model, your area, because we base things based off of our area. Just make sure you find a good ortho. I know I found one that was previously a PT, and he's more the mindset of, keep doing things at PT. And sometimes those parents, and most of the parents and athletes themselves, need that extra reassurance that everything got examined and that sort of stuff. And you need that extra person to say, hey, no, you should continue PT and you should listen. Maybe, don't throw 100 pitches, 3 times a week for 3 different teams, or swim, 3 different practices a day and that sort of stuff. So unfortunately, that's sometimes the case. I've tried to beat my head against a wall of like trying to just convince them on my own end at times. And again, once I heard that PT said that he forces his swimmers to swim when they're hurting, I'm like, I died a little bit on that one.
Yeah, no, he had the, they have to learn how to swim through pain, or they have to increase their mileage. It was tough to hear. Back to your over medicalization. I also try and present things in a non-biased way. I'm sure, maybe I don't always do it successfully, but if you're telling them, hey, this is what I'm going to do as a PT, boom, 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 put those cards on the table. We can send you to, an orthopedist or a physician. This is what they're going to do. X-ray, MRI. We've kind of had this conversation on the show before, and you lay those cards out on the table, and you can say, hey, we did X, Y, and Z. Can say that, there's not going to be a fracture. There's most likely not going to be any tears, especially if they're a young enough age. We need rest, and rehab and yada, yada. And then, you give them that power, make that choice. And if they want to go to the physician, fine. If that physician, hopefully they say what's supposed to be said and done, it kind of puts more validity back in your stock of, okay, I'm hearing the same thing from 2 different places. Then there's the conversation now. How do you handle this, Jer? My coach says this, but your coach isn't the medical expert, right? We are. So, then now there's dealing with that added person that you have to now communicate and get on board. And there's a lot of, it's a lot of persuasion and convincing, for lack of a better term, educating or communicating. But, are we necessarily equipped for that as therapists, especially coming out of school? Do we have time to do that? Do we have time to see patients all day long, and then after that call 2 coaches and have another 20-minute conversation with them? I'm not saying right or wrong. In an ideal world we can, but not all the time do we have that time or luxury or benefit of being able to do that. So you kind of communicate as best as you can to the parents or the athlete, and do what we can. But
hope for the best. So I try and make those calls on my ride home. And that's it. But yeah, it's those are tough. Again, always with the star players and that sort of stuff. And then you're also working with the athlete who wants to get out there more than anything. I've had a couple conversations this week, and it's gotta think of, go back to your playing days and how long you're out for and how much that was torture for you, and compound that with athletes today that were taken out of their sport for a year for not even doing anything, just COVID and everything like that. So they essentially lost a year of their eligibility, high school, that sort of stuff. So definitely compounded from multiple factors here. I've even had an athlete, I don't know if I mentioned it on this episode, swimmer, historically always got injured every couple months and that sort of stuff. And upon conversation with her and that sort of stuff, how it led to was she was borderline suicidal from her sport, didn't really like swimming, actually despised it. but only did it because it made her parents happy. So again, it's got to that point with an athlete, a young girl. Unfortunately for her, she's exceptionally amazing at it, but despised it. It's just kind of crazy. We look at like Michael Phelps and that sort of stuff, and ragged on him for smoking some pot. And yeah, I think dude was in the water more than he was on land in life. Yeah, so thinking about the mental toll on some of these athletes from non-playing and overplaying. So think of those sort of things. But yeah, if we could throw that into the mix. But anything else from an examination point or anything like that there, Brandon?
I would say just to consider, what type of shape, the kid is. Part of it's the eye test is that are they just naturally gifted? Are they more of a motor moron? Do they weight train properly year round? Which a lot of kids don't. They just play the sport over and over and over again. You can't tell me that a kid that plays 3 different sports and weight trains twice a week most times of the year isn't going to be better conditioned and better equipped to possibly throw more pitches than somebody who is sitting playing an Xbox or PlayStation all winter long, and then March 1st comes around and they're expected to pitch twice a week. You can't say those two athletes are equal. And obviously we're not the coach to make that call, but we need to be able to at least recognize who we have in front of us and whether we need to calm things down or speed things up or work on mechanics or work on strength and building up more robust structures with timing and endurance and things like that. So I believe what Greg Cooks, and I've seen this everywhere. You kind of want that pyramid, and you want that general movement to be first. They should move well first, move well, move often. Then we build up strength and endurance, and then we build up our skill. And too often out there is trying to build up skill before having these other prerequisites. So kind of maybe when in doubt, and I guess this will segue into next week's episode in treatment. When in doubt, we want to, address that low-hanging fruit. Can they move well? And can we build up strength first? If you do those two things for most patients or most people, they're going to, have pretty decent outcomes there, or pretty good outcomes. We obviously want better than decent. So I guess I'll leave it with that as we wrap up today's show. Anything on your end, Jerry?
No, I think that was great. And always sort of in the weight room when they're saying they're weightlifting, I'm always questioning who that's with. If it's with a friend,
or what are they
relative,
curls,
parent, or their regular coach. Nothing thoroughly. I've now come to terms that there's your medical provider, there's your sport coach, and then there should be your weightlifting or performance coach. Very rarely can one person do all three. We see it, but you're going to be sacrificing one of those sort of things, and especially ego lifting in the weight room with like previous coaches and that sort of stuff could lead to probably potentially poor mechanics and potentially injury, especially with elbows, doing cleans and that sort of stuff. It's usually males, and there's discrepancy of what training for females versus males are, but males, high school, baseball, football, they're like, yeah, we do cleans and all that sort of stuff. And you ask them to do it in the clinic and you just cringe, or deadlifting or anything like that. And you're like, all right, we need to, so that doesn't count. Let me show you a couple of things and then lead you to somebody else. So you are building the appropriate amount of resilience and doing the right way without exposing yourself to more injuries and risk. But
not to shit on anybody, but you have a 45-year-old coach, 50-year-old coach. Oh, I train my kids because I used to lift when I was younger. Dude, things have changed from 35 years ago when you were 15, and you're doing the same shit you're doing there. Or, I got my training cert last weekend because I do enough training. So I figured I'll learn the trade. Your weekend certification means nothing, dude. And there's that's just another thing. I think training cert should be longer than a weekend, but that's a different conversation.
I agree.
But all right. Anyway, yeah. I guess announcements, Jay. I guess we have. Did you want to say anything else, or
No. I think that's good to finish up on, and excited to talk about the treatment components.
So. Yeah, oddly enough, actually, before we get into announcements, we did today on the shoulder examination, thrower shoulder, and kind of what to look for. But we've had some recent emails on our IOSMT platform on this topic. So if you're not a subscriber, please subscribe, and you'll get. We're starting to do content like this weekly, where we bring up different topics and food for thought and things like that. So check us out there. Subscribe there. We have 4 courses coming up this fall, cervicothoracic in September, lumbopelvic in October at Jeremy's place in Trifecta in Glassboro. In November, we have extremity HVLA, which is quick, fun 1-day course. And then our big hitter, spinal manipulation, in December. So go on our website there, iosmt.com, and check out the dates. And hopefully we see you guys there.
Awesome. All right. Well, thanks for tuning in, everybody, and cheers.
Cheers, guys.